Please start.
A very good afternoon to everyone, all our speakers, our chairpersons, our EICs. We welcome you to the FOGSI JOGI web series Clinical Pulse of JOGI, the 6th episode today. Before we begin our Clinical Pulse of JOGI for today, let's start with the Saraswati Vandana.
ॐ सरस्वती नमो नमः मा सरस्वती नमो नमः विद्यादायिनि नमो नमः हंसवाहिनी नमो नमः ॐ सरस्वती नमो नमः मा सरस्वती नमो नमः विद्यादायिनि नमो नमः हंसवाहिनी नमो नमः ॐ सरस्वती नमो नमः मा सरस्वती नमो नमः विद्यादायिनि नमो नमः.
Thank you, Maria. I now call upon our editor-in-chief, Dr. Madhuri Patel, to give her welcome address and tell us about the clinical pulse of JOGI. Dr. Madhuri Patel is the Secretary General FOGSI. She is the Editor-in-Chief of JOGI. Madam has also been Joint Secretary FOGSI 2009. She is an Honorary Clinical Associate at Wadia Hospital, Honorary Consultant Police Hospital, Mumbai, a Visiting Consultant at St. Elizabeth Hospital, Mumbai.
Thank you, Dr. Pragna. Thank you, Pragna.
I think Madam needs no introduction to all our entire audience. So please, Madam.
Thank you, Pragna, for your kind and warm words. Respected our President, Dr. Jaideep Tang, and he is out of India, so he will not be in a position to join. And today is our guest of honor, Dr. Prakash Trivedi and Dr. Jaideep Mandatra, our past president of FOGSI and great academician. The editor emeritus, my mentor, Professor C.N. Purandare sir, Professor Adi Dastur sir, Dr. Suvarna Khadikar and Dr. Geeta Valsarkar. Today's chairperson, my dear friend, Dr. Ashwini Gandhi, first joint assistant editor, and national corresponding editor, Dr. T. Ramani Devi and Dr. Dipti Gupta. My editorial team, Dr. Sujata Dalvi, Dr. Arun Nayak, Dr. Anaika Chavan, Dr. Ashwini Bhalerao Gandhi, Dr. Pragna Changade, and a secretarial team, I will say my right hands, Dr. Pragna Supe and Dr. Sunil Tambekwarkar, along with Pragna Changade. I will not say my right hand, but I will say they are my right hands. Then, of course, today's speaker, Dr. Shailesh Kutambekar and Dr. Siva Khanam. My national corresponding editor, Dr. Krishnendu Gupta, Dr. Lakshmi Shikande, Dr. Sushil Chawla, Dr. Radhika A.G., Dr. Kiranmay Devyani, Dr. Shobha Gudi, Dr. Dipti Gupta, Dr. Mala Srivastav, Dr. Alka Pandey, Dr. Madhva Prasad, Dr. Krishna Kumari, Dr. Sampat Kumari, Dr. Ashok Kumar, Dr. Subhash Chandra Vishwas, Dr. Nidhi Gupta, and all my reviewers and all my dear friends. Very good evening to all of you. It is a great pleasure and anticipation that I welcome all of you for this sixth episode of FOGSI JOGI, Clinical Pulse of JOGI, an initiative by the team JOGI from this year. What we have realized that we have to give more exposure to our members and also the members who are giving the good articles in our journal. So that's what as an editor of chief, I'm really happy to say that this is sixth episode and first 5 episodes we had award-winning papers in our Jogi and by the Springer, and they were very very interactive session because authors themselves presented how they went about, what was the theme, what was it was done, how it was done. So it was very very interactive session with all these authors who presented their work. So this becomes an inspiration for other youngsters who would like to write in our journal for the same. They can replicate the research work or they can have their own work. So this is the motivation for all our members. So we started with the clinical pulse of yogi, because when we go for the conferences, hardly few people are there to hear them about their work. Of course, journal has a very good reach. It is sent to all 43,000 members all over the country, and of course, it is also accessed by our other international people, and it is very our journal is very well known all over the world. So we want to give platform to our people so they can prosper and they can come out with the best article. Now, let me say that as an editor in chief, it is my honor to introduce our esteemed speakers today, whose insightful article is published in our reputed bi-monthly journal JOGI. This time, we have selected two JOGI best papers of 2020. Dr. Shailesh Putambekar in a senior category for Yogi's base paper title called as Single Center Experience of Doing Safe Total Laparoscopic Hysterectomy, Retrospective Analysis of 1200 Cases. Some of the other, Dr. Shailesh will not be presenting, but Dr. Madhvi Patil is here who will be presenting their work. Then other paper in a junior category, Dr. Zeba Khanam is a second prize winner in the year 2022 for her paper titled Does the addition of serum PAPA and beta HCG improve the predictive value of uterine artery pulsatile index for preeclampsia at 11 to 14 weeks of gestation, a prospective observation study? So these are the very clinical relevant both the topics, and that's why we are happy that we have selected this topic and which can be implemented in our clinical practice very well. So this new introduction clinical pulse of yogi provides us opportunity to understand the article, will also allow us to have meaningful discussion with the authors. I am confident that this initiative will immensely benefit aspiring contributors. And now I invite our Master of Ceremony, Pragna Supe, Dr. Pankaj Anand, and Dr. Sunit Amekar to continue this today's webinar. And some of the other, Dr. Prakash Trivedi had a fall today and he could not join. So now Dr. Jaideep Malhotra is there with us as a guest of honor. So Dr. Pragna, please proceed.
Yes. So, good evening, everyone. I have the pleasure of introducing our chief guest for today, Dr. Jaideep Tang, sir. We all know him as the president of FOGSI. He's the chair of the YGA Committee for. He's a project lead in FOGSI USA projects. He has been the Secretary General of FOGSI from 2018 to 21. He has been awarded the FRCOG honoria causa by the RCOG and he has been the past president of the Mumbai Obstetrics and Gynec Society. Sir is the immediate past deputy secretary of, he's been the immediate past chair of International Federation of Obstetrics and past of the FIGO Committee for Safe Abortion. He has been the past chair of various committees in AOFOG, and he has been a pillar of support for FOGSI, reducing the cesarean rates and various other projects. He's been the technical lead for getting grant of $13 million for a 10-country project. Of course, sir is a consultant at Ashwini Maternity and Surgical Hospital in Ghatkopar, Mumbai. And sir is in Malaysia at present for a program, and he has conveyed his apologies, but he has conveyed his best wishes for Jogi. Let me introduce our guest of honor, Dr. Prakash Trivedi, sir. Unfortunately, sir has had a fall today, so he is, due to his ill health, he has not been able to join, but he has also conveyed his good wishes. We all know him as an endoscopic urogynecologist and ART consultant. He's a director of Dr. Trivedi's Total Women's Healthcare Hospital in Ghatkopar. He is a MUHS recognized teacher for postdoctoral fellowship training in minimal access surgery. He's a pioneer of 3D, 4K laparoscopic, hysteroscopic, various surgeries. Sir has received several awards, even the Health Minister's Awards for research on fibroids. And last time he had his paper on fibroids was very well appreciated by everyone. Let me introduce our next guest of honor. We have Dr. Jaideep Malhotra, madam, with us. We all know madam, she has been the past president of FOGSI. She is a director of ART Rainbow IVF. President of the Indian Society of Prenatal Diagnosis and Therapy, President South Asian Federation of Menopause Societies. Madam has been the immediate past president of ISAR, past president of FOGSI, Aspire, IMS. She is the professor of Dubrovnik University at Croatia, editor-in-chief of CEFOC, and various other journals. She is a recipient of honorary FRCOG, recipient of several awards, including the Lifetime Achievement Award, and she has been credited with first 500 IVF babies. So we welcome ma'am, and I request ma'am to please say a few words for our audience.
Thank you so much, Pradnya, and a very good evening to all of you. It is such a pleasure, to be here sharing this platform with all of you. And Madhuri, wonderful, wonderful initiative. We really were expecting this, and I think these pearls of wisdom are really going to be a great change maker as far as a journal is concerned, because our journal, I am very sure and I am aware that it's doing very well. And the kind of publications which are coming in for our journal are again phenomenal. But not many people actually also read everything, and there are certain things which need to be exposed a little more. People need to be made more aware. And, this awareness regarding all these wonderful papers and their presenters is a great, great idea. And I am very sure in our country, this has always been, I'm sure it's not only me, all of us also feel that we have such a vast, data of clinical experiences, but we don't really have a platform where we could actually, go ahead and publish and present our data and our analysis. And I think this will probably encourage many more people, and our more than the medical colleges, people who have a lot of clinical experience to publish, come out, discuss their, experiences, because I firmly believe that experience builds up practice and practice builds up experience. And this is something which we should be sharing with each other. And really, thank you so much. It is great to see, presentations from Sailesh, again, who's a role model for a lot of all of us. Even at this stage, we would love to see him, doing his surgeries, presenting his clinic, presenting, which is something which I am actually really definitely looking forward to. And also, what is more important today is that we are discussing with the best of the people who are there in the field, the chairpersons, Ashwini, Ramani, and Deepthi, going ahead and discussing. I'm excited and I'm looking forward to these discussions coming up. And I'm also looking forward to this presentation by Zeba, because that's another area where I work a lot in, and I'm very eager to see what the presentations have in store. So congratulations to each and every one of you. I'm sure FOGSI is a great organization, and JOGI is a very, very important academic wing of our organization. And all the best to you. God bless you, and looking forward to all the presentations, and all the best to the presenters too.
Yeah.
Thank you, Dr. Jaideep, for your such a lovely and kind words, which are definitely going to encourage all our juniors and seniors who want to present their work into our journal. And you're always encouraging to everybody, including we all. So thank you very much for joining and taking out your valuable time.
So thank you so much, ma'am, for your kind words. And before we begin the program, I think FOGSI has already come up with a statement condemning the sexual assault and the death of the resident doctor in Kolkata. FOGSI has already released statement, and this program will be left incomplete if we do not condemn this, resident doctor, the state, and the death of the doctors. So we are all with the family of the victim. And I would now request Dr. Sunil to take the proceedings of this program further by introducing the chairpersons and beginning the two talks.
Yeah, good afternoon, respected seniors, faculty, and dear delegates. As Sir Edward Deming has said, without data, you are just another person with an opinion. These are the research principles what we believe in and what we do at JOGI. It's my proud privilege to introduce our chairpersons for the program today. Dr. Ashwini Bhalerao Gandhi, madam. She is senior obstetrician and gynecologist practicing at PD Hinduja Hospital at Mumbai. She has worked as a vice president of FOGSI in 2013. She is past president of Mumbai OBGYN Society 2012 and 13. She has been president of Mumbai Menopause Society 2019 to 21. She has been chairperson of Adolescent Health Committee of FOGSI. She also worked as ex-associate professor at Nayar Hospital, that is Topiwala National Medical College at Mumbai. She worked as secretary at JOGI 18 to 20. Now she is senior editor with us at JOGI. And her important contribution to OBGYN field is she set up the clinic called the Valva Clinic, first in India at PD Hinduja Hospital. We welcome you, madam. We are privileged to have you. Thank you, ma'am. Okay, next chairperson, Dr. Ramini Devi. Madam is senior leader at FOGSI, and indeed she does not need introduction. Madam is managing director at Ramakrishna Medical Center as well as Janani Fertility Center. She was vice president FOGSI 2020. Also worked as international advisory board member at Fertility Society of Bangladesh. She is a diplomat of national board teacher at CSI Mission Hospital for last 5 years. She has been recipient of many awards. Importantly, FOGSI Leadership Awards, Dr. APJ Abdul Kalam Award, Dr. Datta Award, Dr. Nanomani Bose Award, Dr. SN Pandit Award, Best Women Doctor Award, and many more. We are privileged to have you here, ma'am. Thank you very much. Dr. Dipti Gupta. Madam is currently Secretary of All India Madhya Pradesh OBGYN Society 2024 to 26. She is immediate past Secretary at Jabalpur OBGYN Society 23 to 24. She also worked as FOGSI Quiz Committee West Zone Coordinator, co-convener of FOGSI Quiz Committee webinars. She has been part of MEDA FOGSI programs. Madam is working as National Corresponding Editor at JOGI, and she is Associate Professor at Medical College, Jabalpur. We welcome you, ma'am. Thank you very much. I request the chairpersons to introduce our first speaker.
I request Dr. Ramani Devi to introduce our speaker. Can we get the slide, please?
Yeah, slide, please. Yeah, I'm very happy to be a part of this important webinar where I'm going to introduce Dr. Shailesh Puttambekar, who is the Director and Consultant Laparoscopic and Oncosurgeon at Galaxy Care Multispecialty Hospital. He patented the technique of radical hysterectomy, that is the Pune technique, and conducted the first India's successful laparoscopic assisted uterine transplant, and a baby girl was delivered. Only Indian to be the board member of AAGL and member of AAGL Onco Committee, operating faculty at IRCAD and various other international forums. Large series he has published in transthoracic usophagectomy and endoscopic and robotic surgery, known for performing the most difficult laparoscopic and endoscopic surgeries. Pioneer in laparoscopic anterior and posterior excenteration for colorectal and uterine malignancies, and Shailesh Puttambekar has been awarded the prestigious Foundation Signature Award from AAL, recognized worldwide as the Golden Telescopic Award. He has received the same award from AAGL 4 times. That is something commendable. And for in the past and for his excellent work in this 5th award. Shailesh Puttambekar has been selected as the International Secretary Treasurer of AAGL, and he will be the first person to hold the prestigious position and work closely with the AAGL board to promote the and teach laparoscopic internationally. We welcome you, sir.
Thank you so much, ma'am. And I believe that we have Dr. Madhvi Patil who would be presenting this paper on sir's behalf. And the first paper that we are going to be discussing today is, before I share the topic of the first paper, I'm extremely grateful to Madhuri Patel ma'am for giving us this opportunity and making me a part of this esteemed audience and this highly academic initiative by Team Jogi of Clinical Pearls. And my humble regards and greetings to everyone present here. And the first paper that we will be discussing today is a single center experience of doing safe total laparoscopic hysterectomy, which is a retrospective analysis of 1,200 cases. The sheer volume and the number speaks a lot, and I think this kind of data will go a long way in introspecting on the work and improving the techniques further. And I would also like to add that this was actually published in 2020. So you can imagine between then and now, the further amount of volume of work with improved techniques that must have been done. So we have Dr. Madhvi Patil with us, if I'm not mistaken, who would be presenting this first paper. Yes, ma'am.
Yeah, she's there. Maria, please allow her to share the screen.
Madam, she's allowed.
Yeah.
So hysterectomy, as we all know, is one of the commonest gynecological procedures being performed in our country. And endoscopy is definitely the way forward with improved recovery, faster ambulation, better safety profile, better visualization, less tissue trauma, so on and so forth. And this is a very good analysis of 1,200 cases of total laparoscopic hysterectomy. So over to you, Dr. Madhvi Patil, for the paper presentation and discussion.
Yeah, thank you so much, ma'am. Good afternoon to everyone. Can you please give me a share screen?
Madam, you
Thank
can
you.
share the screen.
I got the access. Yeah. 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 So good afternoon, all. This is the paper which is published in 2020 by Dr. Shailesh Puntambekar and the resident doctor under him, that a single center experience of doing a safe total laparoscopic hysterectomy. It is a retrospective analysis of 1,200 cases. So, hello to everyone on behalf of Dr. Shailesh Puntambekar. Sir, before going to the thing, I just make it a highlight on the history that the first abdominal hysterectomy was conducted in 1843, but it was an unsuccessful one. The successful one has been performed in 1853, and the first laparoscopic hysterectomy is performed in 88 by Harry Rich. So the in India, it is 4 to 6. This is the data of 2022. 2020, that is 4 to 6% of the incidences of hysterectomy, 90% of it for the benign conditions. So the introduction of this is that we are comparing the TLH with other procedures like abdominal hysterectomy or vaginal hysterectomy. So basic emphasis on the assess of the safety and feasibility of minimal access surgery for the benign condition, that is TLH for benign conditions. In this is our paper which has already discussed. So the study design for this is a retrospective analysis in the training center, and it is a tertiary care center, Galaxy Care Pune. We have conducted this study from July 13 to June 19. And objective of the study is that the safety and feasibility of total laparoscopic hysterectomy. So the inclusion criteria for this is the pathology, basically the uterine myoma, adenomyosis, chronic PID, postmenopausal bleeding, endometrial polyp, endometriosis. The data which we showed is the endometriosis is lesser percent, but nowadays we are getting more patients of endometriosis rather than the other things. So we included the uterine size of less than 24 weeks of just weeks, and previous surgery, LSCS, appendicectomy, or previous laparotomies, we have included all them. The medical risk factors, hypertension, diabetes, hypothyroidism, and asthma, we have included in. But the exclusion criteria is that suspected malignancy, mass more than 24 weeks, or any mesh repair surgeries, or any cardiac disorders. So our results for this, we are starting with a mean age of 45 years. The distribution of BMI distribution in that the patients which we get is 18 to 24 of BMI, 72% patients we got. So the indications, this is the thing. I already discussed the indication. The most common indication for the TLH we got is the uterine fibroid. So previous history, this is showing that previous LSCS is having a 75% of the patient are getting in this. Then appendicectomy, myomectomy, endometriosis, and any cystectomy or oophorectomy prior to that. So the women who are undergoing, this is the thing that 12 to 16 week size uterus is the most common we have done in this. And after that is the 6 to 12 week size. And the least is the 1%, that is the atrophic uterus. So for this, we have done the preoperative workup, in that all the blood investigation, X-ray, ECG, and all that, and anesthesia and physician fitness has been done. Proper consent has been taken from the patient. So after that, we prepared the bowel for the surgery by giving the Peg-leg or this Dulcolax suppositories. Then we, prior to the surgery, 2 hours prior, we give a single dose of intravenous antibiotic. So the anesthesia which we used in this is the combined regional plus general anesthesia. So why the regional anesthesia is to block the sympathetic activity so that it contracts the bowel and keep it aside from the operative field. So this is the modified Davidoff Davis position which we give, and the bolster is kept below the anterior superior iliac spine to elevate the pelvis, and which drops the intestine cephalad. Then port side position is like we inserted under vision, we insert the VZ port at the palmer's point. After that, the camera port is infraumbilical or supraumbilical depending upon the size of the uterus. And the right side is the 5 mm port, forefinger away from the camera port. And again, the forefinger away from the 5 mm port is the 10 mm. This is the right side operating port. And then the replica of it is 5 mm, 5 mm on the left side for the assistant port. And so we are making a C, that is the opening C over this. This is the port position. So basically what we use for the manipulation is the tenaculum and the myoma screw. Use of energy sources, we use bipolar ligation and harmonic Salk bill. For retrieval of the uterine specimen, most probably sometimes we required a morcellation, in that we are using the vaginal morcellation or the morcellator for this. No monopolar cautery has been used in this. So basically what is the technique? Everybody is doing the TLH, everything is there. But I just wanted to highlight on this. Whichever structure comes, we have done the salpingectomy. After that, we are clamping the ovarian over here, the 3-clamp method. After that, opening the round ligament, cutting the round ligament. Once we cut the round ligament, we open the lip of the broad ligament, that is the anterior and the posterior lip of a broad ligament. In this, we open this, and we are now till the apex of the uterosacral, we go till down to delineate the vessels and also to retract the ureter laterally. So then afterwards, anteriorly, we do the bladder dissection. In this bladder dissection, the dictum is fat belongs to the bladder. We have to be in between the fascias, that is the cervicovesical fascia. After clearing the bladder, dissecting the bladder, then we will clamp the uterine. This is the 3-clamp method. We are using the bipolar and a harmonic in this situation. So we are now pedicalizing the uterine stump here. After pedicalizing the uterine stump, we are going medial to the uterine stump. And now, see, this is the opening. We have opened the vault at posterolateral aspect. That is the white of vagina. And then we proceed. Once we open the vagina, then circumferentials, that is the circumcision of the cervix we are doing. So in this way we have completed, and these are the steps which are repeated on the left side also. And this is the replicable, duplicable things. That's why this is very much important. Then I am highlighting on this, that is a bladder dissection in the previous surgery patient. That is, this is a patient of previous 3 LSCS patient. So basically we tried anteriorly that, but it is a stuck up bladder over here. So for this, we use a lateral window technique. And now see, if I have to go, I will go down to this adhesion, and from that I will dissect. And I am using over here, it is a sharp dissection with the scissor. I'm not using any energy source over here. So, so this is the thing. I have go down here and I am opening the part below the adhesion. See, this is the cervicovesical fascia. I am lying between the fascia, and fat belongs to the rectum. So, sorry, bladder. So this is the thing. We are dissecting with the scissor. After this, the thing is ki you lie above the sharp dissection is done. And this is the uterine stump. I have to lie above the uterine. So that is the thing. So exactly, entire bladder has been dissected. So this is the technique which is used in previous surgery patients. So wall suturing, I'm not that much highlighting on the wall suturing, but we are using a Vicryl 2.0, and we do the wall suturing in continuous interlocking fashion. So wall suturing we do. This is the thing. So what are the surgical details? So surgical detail, the mean operative time which we required is less than 60 minutes. Only in the cases of endometriosis, we got the time which is more than means 90 minutes, more than 90 minutes we required in that, because of the adhesions and the fibrosis which is there. So what is the blood loss? Blood loss is less than 50 ml. Like 60% patient, we got a less than 50 ml blood loss. And intraoperative complication, the total number of cases which we got is the 24 patients. In that, we got most common is the bladder injury because of the dense adhesions. And so we have suture it immediately in between the surgery. For the ureteric injury, it is basically in the patients with an endometriosis. So we have done the bilateral degestenting for them in intraoperative. So oral intake, we start the patient on orally after 6 hours of the surgery. This is the most common, that is 31% of the patient. Post of day 0, 58% of the patient got the oral intake. Hospital stay, the patient, basically we discharge the patient on day 1 or day 2 of the surgery. So hospital stay reduce after day 3. The post-operative complication, in the post-operative complication, they are minimal, but we found the fever, urinary tract infection, or paralytic ileus, or urinary retention as the most common one. So complication may occur. So anticipate the problem before it comes. So where the complication may happen is the patients with a previous surgery, obstructed bowel, or large masses, or pelvic inflammatory diseases, or any patients with an obesity. So the discussion is the comparison is with the previous studies, the TLH outcome in the high volume center like a Galaxy Care. So there is a safety and efficacy is there for the TLH, and there is a low complication rate. So that is the thing. The learning curve, the average surgical time decrease with an experience, and also the mindset to be changed for this. So advantage of this is that the TLH which we offers is the advantage in shorter recovery times and less blood loss, and so less post-op complication also. So this is a helpful thing for the high volume center like us. The limitation of this is that it is a single center study. So that is the only limitation. So my conclusion is that the TLH, when it is performed in high volume center, well training center, the safety and efficacy has increased. The advances of equipments, like we can use like like assure a harmonic, that will increase the efficacy also, and standardized protocol. The TLH which we are uh, s- uh, studying means and teaching the student, it is always a duplicable method. So despite of the limitation, the study supports the TLH, and this is my conclusion. So acknowledgement from the Galaxy Care, and thank you everybody for giving me this opportunity to present. Thank you so much. I'll
Thank you,
just
Dr.
request.
Madhvi. You have presented very well.
Yeah.
Can I ask some questions?
Yes, ma'am. For the question session, sir is coming. So I
Okay.
just request him to come. Okay.
All right. All right.
Okay. Just hold, ma'am. Thank you.
I think you can stop slide sharing, huh? So we can see each other.
So, Dr. Ashwini, that was a very, very fantastic single center study on total
Yes.
laparoscopic hysterectomy,
Yes.
and the experience they would have gained as day goes on. There definitely the incidence of complications will be very, very low, and my appreciation to the surgeons and the assistants and the entire team who has done a fantastic work.
That's
And
what I
my
wanted to
is Dr. Kailesh hasn't joined? Has he
He's
joined?
joining, I think. Yeah.
One
I'm
of
here,
my
madam.
colleagues.
Hi, I'm here.
Hi, Dr. Shailesh. This is Dr.
Good evening, sir.
I
You
know,
are
I know.
very
I was
close to
listening to what
join.
Madhavi was saying. She's our consultant and she presented the paper. I am here only.
Yes, yes. So we are very nice to see you,
Yes, madam.
and we are here to hear you from you. There
Yes.
are few questions from the chairperson and also the
Sure,
others.
sure.
So you can share, Dr. Ramni Devi, Dr. Ashwini, the questions.
Yeah. Dr. Puntambekar, it was a very nice study. And I wanted to ask you that is it done only by you, the cases all? Or your team has done the cases? Because
Madam, all the cases have been done all by my team only. The
Huh.
next paper that we have also presented in that is about the learning curve for the residents.
Right.
If you see, that is also immediate follow-up of this paper. So 80% of these have been done by my consultant gynecologist as well as my resident. We have a fellowship in gynecology from MUHS.
Yes.
So everybody on an average gets about 25 to 30 hysterectomies a year to be done laparoscopically. And it is
Madam, in fact,
supervised.
sir, if I may add, one of my colleagues, Dr. Jyoti here, has trained under you.
Yes.
And today I was discussing with her, and she's reiterated the same thing, that there is exact same protocol steps which everybody has to follow. So
Yeah.
there is no scope of confusion or mixing up or goofing up, and everybody goes the same way. And which is why I think you were able to analyze your data so systematically in a very structured way.
Madam,
Dr.
that is
Puntambekar.
true. Yes,
No,
we
you
are.
go ahead, sir. You first
Okay,
answer.
madam, see, the thing is, when I entered laparoscopy, we always had a lot of issues about everybody having an individual protocol. So we thought we should devise the steps which are duplicable. Because if I cannot train the junior in a particular way, then the whole purpose of that surgery is lost. So 15 years down the line, my residents who have been trained 15 years back, they come and say, sir, you have not even changed a single step. As long as we don't get into complication or unless there is a problem, there is no reason for us to change the steps. So a lot of steps are designed, and so far we have been able to do this very carefully and nicely.
Sir, in your study, it is mentioned that you didn't have to convert to laparotomy in any case.
No.
But do you still take consent that SOS laparotomy will be done?
It is 200%. We always take a consent. We still have an open trolley ready next to us, open surgical instruments. So it is like, I always tell them, it's like going in an airplane. You need to have the checklist. Anything can go, and you know why? The reason, if you look at the LAC trial, the trial which actually stopped the cervical cancer treatment in the world, if you see 35 patients were converted to open. And if you look at the cause for opening was because of non-use, the carbon dioxide getting over, or the camera system failing, or the energy sources failing. And you can go through the trial and LAC trial, which prevented us from doing cervical. So in an international level also, 35 patients had to be converted because of failure of instrumentation, not because of human failure, but failure of instrumentation. Fortunately, we have almost about 7 cameras and 10 encephalitors. So all 3Ds. And that is one of the reasons that we did not convert, because the failure always takes place. The CO2 doesn't work at times. Sometimes the energy source fails. But we have 5 harmonics, 5 ligatures. So we just wait and do this. But the failure of the equipment is the commonest cause. And the last cause is, in the last about first time in my life, 2 radical hysterectomies had to be converted to open. And you will be surprised to know they were mainly because of carbon dioxide embolization, which took place through a small vein. The EtCO2 went down to 1 and 2, and we realized that, and then we immediately converted. But the patient had to be given cardiac massage. Patient came out finally. But that is the only, in my 15, 20 years of laparoscopy, only 2 patients where we had to convert because of medical reasons. But surgical failure of equipment doesn't take place. And that is one of the good things of any institute. You should have enough backup.
So in your protocol, do you have any specific treatment prophylaxis against DVT?
We always do, madam. We have a DVT pump intraoperatively, and it is our protocol to give Clexin about 8 to 10 hours after the surgery, because we are under-reporting DVT in our country. That's what we feel. We have lost 2 patients of DVT of endometrial cancers with 40 BMI. And that too, after 48 hours, when we send the patient home, they strained very heavily at their house. And then they got so we have been doing this for a long, long time. DVT pump 100% above the 35 BMI. DVT pump continues to be there for the next 48 hours. Usually 48 hours later, the patient goes home and we try to ambulate. But DVT is very, very underreported in our country. It is very common.
So, sir, Clexane for all TLH patients?
Clexin, yes.
Okay.
Because one dose of Clexin doesn't matter, and it doesn't, because if the hemostasis is good, I am not sure whether the BMI is related to that, but it is the time that is taken as the residents become a little bit more conversant, that the time taken is less. But the initial phase, everybody takes in our institute 1.5 hours to 2 hours. So, and the time is different because it is done by the junior people to begin, sometimes senior, sometimes senior. If I do it, it will be 20 minutes. But I don't do it only. So that is the reason.
Sir, what about the removal of the tissue, sir? Whether you use a morcellator or in-bag morcellation or just open morcellation or vaginal morcellation?
Sir, madam, before the 2014-15 paper, we were using power morcellation, and that too without the bag. So let me be frank that we didn't have this putting it in the bag. So for a large uterus, we were using power morcellation. But now if we can do it, we do it in the bag or we do a vaginal morcellation. Sometimes we have 24 and 25 weeks uterus. Then we take a consent for a fan and steel incision and take out the tube, take out the entire uterus. That is very sure. But we are not morcellating now. Not without contained morcellation, we don't morcellate now.
I think up to 16, 18 weeks, we can go for a vaginal morcellation very safely.
Yeah, they do vaginal. We have, and gynecologists actually are fantastic vaginal surgeons. So they can take out anything from below.
Sir, what about antibiotic prophylaxis? Which antibiotics do you prefer and how many doses?
We use venom 1 dose intraoperatively, that is monosef. All our patients come in the morning. When nobody gets admitted one day earlier, they all come in the morning. They give 1 shot of monosef intraoperatively, 1 shot of monosef postoperatively, and 3rd shot in the next day morning. And then there are no antibiotic, or if required, oral antibiotic, nothing more.
Okay, sir. So then if you are going to give a thromboprophylaxis, how many days you give, sir?
Actually,
For a morbid, like BMI more than 35 or 40.
Madam, anything which is above the 35 years of age, minimum of 3 to 4 days, we give prophylaxis. If the patient is ambulating, then after 3rd day, you really don't need. You have to keep on telling them to ambulate. And the best form of exercises we tell them is to stand on their toes and do at least 20 times. So you stand and on the toes you do this. So it helps your calf muscles to grow this. So all this, I have a huge residential, I have about 11 residents working for me, FNBs and MUHs. So they are all trained to do this because everybody wants to operate, but they don't have protocol for post-operative care, and which is very critical. But we use for 3 days, more than 35 BMI.
Okay. Do you use ureteric stenting in very difficult endometriosis surgery?
Madam,
Do you think it is going to be of use or no use?
No. Your answer to this is, for any kind of surgery that we do, we don't do prophylactic stenting. But we do the stenting if at the end of the surgery, we feel that we are very close to the ureter, or in endometriosis, we feel it is there, then we do stent. So post-operative stenting is more of a norm in our institute. If we feel that it is not correct, number one. Secondly, if we feel that too much of energy source has been used, we do that. But we are not in favor of preoperative stenting. And I have burnt my fingers because with preoperative stenting, the residents become too confident. And with the stent, they damage the ureter. And also the ureter pliability is lost. So you can't dissect it so well as compared to that. So we have we do stenting. We do at least 1 in 50 patients. We have to do the stenting, even if in a big TLH patients, if we feel that we are very close to the left ureter, which is what actually happens. And you see, if you see worldwide also, the ureteric fissuras are very commonly seen more on the left side. 90% of the gynecologists operate from the left side, and it is the ipsilateral side which causes more problems. So that is what is there. But we do post-operative stenting, and all my residents are trained to do stenting. So we do not need urologists at any time.
How do
Dr.
you...
Puntambekar?
Yes.
Yeah.
Hello.
How do you manage your dense bladder additions, sir?
Madam, we have actually published our data, published our thing that how to manage the adhesions. We go according to the anatomy. We come from the lateral side. And in the lateral side, we first identify the uterine. So if you remain anterior to the uterine artery, and if we go below the fat, invariably you will get a plane, even in the 3 or 4 cesarean section patients. We come from the lateral to the medial side, never from the medial to the lateral side. One other trick that we sometimes use, which is very, very commonly used in our, is to put a gauze piece inside the vagina and make the anterior vaginal wall more prominent so that you can rub on the vagina and push the bladder. But these anatomic dissection, we don't allow our residents, or I also, in many workshops, you must have seen, I do the anterior dissection only with scissors. I don't use any kind of energy source. And remaining anterior to the uterine artery and remaining below the fat is the key to go from the lateral to the medial side. A lot of people also inflate the bladder, but we do this inflation test at the end when we have done a hysterectomy to find if there is any leak. But if you inflate the bladder, it comes in your way. I'm not in favor of inflating the bladder and doing the surgery.
Sometimes the entire posterior wall is adherent to the anterior abdominal wall, anterior surface of the uterus.
Yes.
In that case, how will you manage? Because there
Madam,
will
it
be
is
dead conditions.
the simplest technique is to do colpotomy. So you do posterior colpotomy. Then
Okay.
is the colpotomy posteriorly to the anterior side. So when you see that, it is densely adherent, so you get the vagina to hold. You know where the vagina is hold. So we do what is called as a retrograde hysterectomy. We never do antegrade hysterectomy. So we have trained for this. So we do posterior colpotomy. You can get the uterus more mobilized, hold the cervix, hold it back. You see the vagina anterior wall because you see that. And then anterior colpotomy, you can go from below upwards and cut it. So doing a colpotomy is the trick if you have a very, very dense bladder which is adherent.
Thank you, sir. Thank you.
Can I ask one last question?
Yes,
So you
madam.
must be getting many women who are coming out of Pune, even
Yes.
out of India.
Yeah.
So till how long you advise rest at home, and when you will permit them to
2000
fly?
petrol.
Madam, we normally we don't have still the guts to have the ERAS protocol of discharging the patient on the same day. So ERAS protocol says that you should discharge the patient on day 1, but we start the feeds on day 1, we discharge the patient second day. We get a huge number of patients coming from all over India for endometrial cancers, which are 40 BMI, because no gynecologist wants to operate on 40 plus BMI. And they are all on our table every day. So, but they remain in the hospital for almost 48 hours. If it is possible for them to be in Pune for another 4 to 5 days, that is fair enough. Otherwise, they can fly and then we contact the gynecologist who is there in that town to tell them and look for XYZ signs and go. Recently, 2 of our patients, I did radical hysterectomy. They went to a Vietnam trip after 5 days. So the basic trick in this is to prevent any kind. The biggest problem after a hysterectomy, I feel, is not the secondary marriage. It's the wall dehiscence. And that's where we are very particular, madam. We have to take we train them because this is the end of the surgery and people feel it can be done any shabby way. If you want to have no complications in a hysterectomy, it is the wall closure, which is finally the patient is going to have wall closure, which patient will feel you are a good surgeon or a bad surgeon. A little bit of discharge from the vagina, little hole in the vagina, and then your good surgery goes to toss. So this is what we train them very, very extensively. But outside India, they remain here in Pune for 7 days. Inside India, if they have the ability to stay for 4 days in Pune, otherwise, then we tell them to go and take care of them in their respective towns.
Dr. Puntambekar, I have a question. I'm Dr. Shobha Gudi from Bangalore.
Yes, ma'am.
I just heard so much about you and seen so much of your work, I'm thankful to JOGI. They have built this interactive platform today.
Yes.
Dr. Puntambekar, I just wanted to have a little more insight on your ergonomics in depending on patient, characteristics like obesity or size of the uterus.
Yes,
I have
madam.
always found that very challenging because,
Yeah, that is a very excellent question, madam. So normally, if the uterus size is between less than 20 weeks, the port position is always infraumbilical. But if it is more than that, we shift to supraumbilical ports. So it depends on the size of the uterus. If the uterus is too big above the umbilicus also, we shift to more 4 fingers. Our policy is very clear. So our policy is 4 fingers. We use 4 fingers and wherever the uterus is palpable, big 4 fingers, just cranial to that we go. And all our ports are 4 fingers away from that. So this is the basic way in which we put. We keep on shifting the ports more and more cranially if the uterus is very big. And that is how we do. We operate ipsilaterally. So we always have to I'll just show you the port position if that is there. Yeah, so this is the port position you can see. These are 4 or 5 ports that we use. We don't use any manipulator from below. And that is the reason one port is for myoma screw. One port can be dispensed off. We do uterine hitch technique, but the surgeon stands on the left side or the right side. and we use the ipsilateral ports. We don't use contralateral ports. And my teaching is to keep the elbows always below the shoulder. If the elbows go above the shoulder while surgery, you are going to goof up at some kind of time because you get tired. So we do operate like this on the ipsilateral side, always.
Any more questions?
Yeah.
I just Ashwini, I
Yes.
just wanted to know, when he says always ipsilateral, is it that he will change side when he is doing on the right side?
No, madam. We don't shift the sides. So we, even in a big uterus, what we do is, if it's going to be difficult to do the left side or the right side, the contralateral side, then we help our assistant to do that side. But
Correct.
I don't shift
Yeah,
the
yeah.
side. Because
Yeah,
it's better to give the energy source in their hand and
Yeah,
let
yeah,
them
yeah.
operate. And you are under control, so you are always under control. So, but shifting the side is difficult because at every time that we operate, we have two monitors, one at the foot end and one
Yeah.
at the left side. So we don't shift our
Yeah, the dissection at the bladder end will be not a problem, but no, from
No,
the left side,
it is the contralateral side, madam, which is always a problem. But
always
the
a problem.
contralateral side, especially in big uterus, we tell the assistants, we give the energy sources to the assistants' hand and we guide them. So they are also happy to do the surgery.
Yeah, yes. Thank you so much. Thank you.
Thank you.
Dr. Sunil wants to ask.
Dr.
Hi,
Sunil,
sir.
yeah.
Hi, sir. I'm Dr. Sunil here. Really glad to see you.
Yes,
I'm
hi.
assistant professor at Wadi Hospital. I have met you at many occasions at conferences, and we are a fan of your retroperitoneal dissection. Few basic questions at the end of the presentation. Sir, one of the port which is lateral and lower is 10 millimeter.
Yeah, that is, we started using 10 millimeter ports and we continue to do that. This is for two reasons. One is sometimes we always teach the people to ligate the uterine artery. So we use the plastic hemolog clips to put them and put them into the, as the resident goes higher and higher after 2025, I teach them how to identify the ureter, because doing hysterectomy, they get too confident at times. And then they start, when they go out, they are doing hysterectomy without realizing the position of the uterine and the ureter. So everybody goes through the training of pararectal. Everybody does pararectal, and that is the reason to put the clips, 10 mm clips, we put that. Secondly, we use a 10 mm port also to put the sutures which can immediately go, because these operations are, as I said, 80% done by my residents. So if there is any bleeding, I want to put a suture. Otherwise, I have to use a 5 mm outlet and put the, so suture passer, suture and the clips, and the third thing is to put gauze pieces. So we are used to this 10 mm port, but when the patient is very finicky and they are very high profile patients, we use 5 millimeter port. But for practical training, we have been using 10 millimeter port. The thing is that, as I said, 80% being done by my residents and my fellow consultants. We want them not to lose their confidence at any point of time. And that is the reason all these steps were designed. 10 mm port, if I operate, it can be substituted with 5 mm because I never require more than 10 or 15 ml of blood losses there. But then it is not about me, it's about the cabinet. So we are still continuing to use a 10 mm port.
Okay, thanks, sir. Sir, do you prefer pre-op or ureteric catheterization, like liberally?
No.
No.
Now, for all the people in the world, we have started using the ICG inside the ureter. But again, I am not in favor of using the ICG. It keeps on looking green on the entire during the dissection. What you can see better, what are we worried about? And at the end of the surgery, if you feel that you have damaged the ureter or very close to the ureter, just stent them. No, what is the problem? No preoperative stent.
I'll take 5 minutes.
The last question.
Yeah.
Hi, madam. Good evening, madam.
Sunil, I had only one question. I hope that it is permitted on energy source. His opinion and his views on energy source, which one he prefers and why?
Madam, we have a array of energy sources from bipolar to monopolar to Ligashore, but my choice, if you ask me, is harmonic and bipolar. It's very, very good. And for pedicles, Ligashore is good. So infundibulopelvic ligament, you can just clap it and do it. For uterine, you can use Ligashore. But for dissection, I prefer to use bipolar and harmonic. Well, I have a bipolar in my left hand and harmonic in my right hand. So bipolar does the coagulation and the harmonic is used like a scissors. So it helps you to do the surgery. But all my residents operate with Ligashore because they find it very easy and very, very easy to clamp the pedicles. They use it Ligashore. But when you go very close to the colpotomy area, Ligashore doesn't take the clamp. That's where you have to shift to either monopolar or to harmonic.
Thank you so much. Thank you.
Dr. Jaideep Malhotra is around. Dr. Jaideep, would you like to say something? Dr. Jaideep? I think she's just on. Dr. Shailesh, I am really congratulating you for doing a great work, and I'm really happy. I know that you are making so many residents and the junior to work on this, so they are confident about the laparoscopic surgery, because today's need of the hour is laparoscopic surgery.
Yes,
Convention is not done. It is only, in the case of complication, we are going to go for the laparotomy. And I'm very, what you say, the cesarean section which you had hysterectomy patient, 75% of patient you had a previous cesarean section.
Yes.
So before, talking to others, we should be prepare ourselves that we are going to deal with all previous cesarean section in future for the hysterectomy, and we have to be prepared for the bladder. Means we have to take care. In spite of taking care, we can land up with the bladder injury, and you have to know how to suture and how to deal with it. So, and you have informed us very well, Dr. Madhvi, that if you have lots of adhesion with bladder, it is better to go from the lateral window where you can find some space, and then the fat is of bladder. So that is the most important message you have given, how to avoid the bladder injury. I wanted to know about endometriosis. You said more than 90%, 90 minutes were taken for endometriosis. So I just want to know about the frozen pelvis. When you have frozen pelvis, sometimes when we used to do a laparotomy, we could not lift up the uterus in a frozen pelvis, especially tuberculosis when they have a chronic pain and all. So have you come across such type of, uteri where it was difficult to lift up from the pelvis?
Madam, actually, we have a paper which is also published in JOGI. So we have a lot of papers in AGL journal. So there we have published 150 patients of stage 4 endometriosis with nerve sparing surgery. And they were all stage 4. I don't get a patient primary endometriosis. Always it has been operated by 1 or 2 gynecologists and not able to reach that area. And we get all goofed up cases, especially if there is a rectum involvement, we get all these cases. But then the thing is to remain very, very, very true to your anatomy. You always start from the virgin area, from the sacral promontory, and then go downwards, because there is no pathology in the world which reaches up to the sacral promontory. So start your dissection at sacral promontory and start identifying the entire structures from the cranial to caudal. Our first thing that we do some majority of the times is to go into the pouch of Douglas, try to separate the rectum there. Never do it. Come from the lateral side and everything will be easy. If you look at any endometriotic surgeon who's doing, they all start from the sacral promontory. The reason is no pathologies, and this is what we wrote long time back, that no pathology in the pelvis goes up to the sacral promontory. When in doubt, start your dissection at sacral. So we get a lot of frozen pelvises, but so far so good. We have been able to tackle each one of them so far.
Very nice, very nice. So Dr. Ashwini, our chairperson, Dipti, and Dr. Ramni Devi would like
Thank you, madam.
comments, and we are very happy to have you with us.
Thank you, madam.
This
Anytime.
Clinical Pulse of JOGI, we started from this
Yes,
year.
this is a very good thing. The paper should be discussed more and more. We are just about to send another article to you because we published all the anterior parametrium against LAC trial and everything. We also published our nerve sparing data. No Indian has ever published. This is a very difficult data to publish, because if you ask a woman what is your sexual experience after the surgery, they come and kill you. So, they feel that you're taking some pornographic movie and all that. So that is, our resident Sneha Venkateshwaran, who is now a lecturer in Sion, she painstakingly and interviewed 150 patients and we published in JOGI. And now we are publishing a very, very good paper about our experience with the ICG also. We've crossed now more than 400 patients, and that is also coming. So, madam, anytime we are more than happy to discuss anything clinically. Thank you, Jogi. Thank you, all of you, for inviting us. Thank you, madam.
Thank you. Thank you.
Thank you, sir. I once again thank you, sir, and all the chairpersons. I request chairperson to introduce next speaker.
Dr. Ramani Devi or Dr. Dipti?
Yeah, I'm here. So I welcome the next speaker, Dr. Ziba Khanam, who is a specialist in the Department of OBGYN, WMMC and Safdarjung Hospital, New Delhi. She is a member Indian Society of Colposcopy and Cervical Pathology and NARCHI, member editorial board of AOGD, awarded the Dr. Neera Agarwal Gold Medal at the 37th AOGD Annual Conference in 2015, awarded FOGSI Prize for the best paper published in the journal at 65th AICOG 23, received ZL Javeri for the award for the best paper presented at 66th AICOG 2024, and numerous publications in national, international, and state level journals and books and chapters. So with this introduction, I welcome Dr. Ziba Khanam for a very, very important article, that is, does addition of serum PAPA and beta HCG improve the value of uterine artery pulsatility index and for preeclampsia at 11 to 14 weeks of gestation. That was a prospective observational study. Dr. Ziba?
Thank you, ma'am, for the introduction. Ma'am, I hope the slides are visible.
Yeah, it is seen. It's very well seen. Go ahead.
The title of my paper was, does the addition of serum PAPA and beta HCG improve the predictive value of uterine artery pulsatility index for preeclampsia at 11 to 14 weeks of gestation? It was a prospective observational study. I was a postgraduate trainee, ma'am, when I conducted this study as a part of my thesis. Preeclampsia is seen in about 8 to 10% of Indian pregnant women, and we all know that it is associated with grave fetal and maternal prognosis. So what happens in normal pregnancy is that there is endovascular trophoblastic invasion, which occurs by invasion of decidual segments of the spiral artery at 8 to 10 weeks, and the second wave, there is invasion of myometrial segment of the spiral at 16 to 18 weeks. Now, during this invasion, there is gradual loss of normal musculoelastic component of the arterial wall and its replacement with fibrinoid material and trophoblast. So, the basic defect we all know in preeclampsia is faulty defective deep placentation during the second wave of the trophoblastic invasion due to the failure of expression of adhesive and invasive signal molecules. So overall, there is failure of conversion of high resistance, low volume flow to low resistance and high volume flow. So this alteration in uterine artery flow could be represented as high resistant flow divided by peak systolic velocity. So we all know that PI, since PI is independent of this peak systolic velocity, it provides a better idea of flow in the vessels. And resistance index, for example, if the systolic velocity somehow the SD ratio is 0, so in those cases the resistance index will reach to infinity, which is not logical. So PI was taken as a marker for flow in our study. Now for blood sample processing, we centrifuge the sample at room temperature for about 10 minutes at 400 rpm the separated serum was analyzed for PAPE and HCG using ELISA immunoassay technique. The values were then converted into multiple of medians according to the lab reference values. Now, these women were asked to follow up as per hospital protocol up to delivery. And at each visit, they were tested for body weight, blood pressure, and urine albumin using the dipstick test. All the women were followed up for primary and secondary outcome. So we defined the primary outcome as presence of preeclampsia or gestational hypertension. Preeclampsia, we all know. We took the standard guidelines for actually this study was conducted in about 2016, year 2016. At that time, the new criteria, the new guideline for preeclampsia had not come into play, and so we took the study was done using the older criteria for definition for preeclampsia and gestational hypertension. That is why presence of proteinuria was included in preeclampsia. It was an important part of preeclampsia and gestational hypertension. Blood pressure, rise in blood pressure in absence of proteinuria were taken as gestational hypertension. Now, secondary outcomes, we also took some secondary outcomes. These were preterm delivery, low birth weight, and fetal growth retardation. Again, we did not go, because the study was conducted in 2016, we did not go to the ECOG or the Delphi consensus guidelines, which have differentiated now FGR into early and late onset. So we took simply FGR as less than 10 centile for gestational age with abnormal umbilical artery Doppler findings. Now, data analysis, we use it using the Microsoft Excel Stat and MedCalc software. For all the data that was collected, we drew receptor operating characteristic and area under the curve diagrams for each one of the markers of interest, and we then drew out the optimal cutoff point for each one of the markers and the corresponding predictive values of these markers for predicting preeclampsia and gestational hypertension. So now first going into the results. Out of a total, we recruited a total of 118 women. Out of that, 18 were lost to follow-up and 100 women were available for a final analysis. Out of that, 9 women developed preeclampsia and 5 women developed gestational hypertension. One had FGR, 9 had low birth weight, another had abruption and preterm labor. Now, the majority of women, 33% of the women belong to 12 to 12 plus 6 weeks of gestation. Most of them were primary gravida. They were between the age group of 20 to 25 years and had a BMI of 18.9 to 24.9. Now, coming to this important table, we found that the uterine artery, the mean value of uterine artery PI, in this table we are showing the mean uterine artery PI as 1.56, serum PAPE is 1.15, and serum beta SCG as 1.5, medians of multiple of medians. So when we plotted the graph, as you can see, we found that the uterine artery PI showed a gradual decline over 11 to 14 weeks. The serum PAPE showed a gradual rise, and the beta SCG value showed a gradual decline again in the study. So which were very consistent with the normal flow patterns or normal pattern which is seen in normal pregnancy. Now, on plotting the ROC curve for uterine artery, the AUC was highest, 9.34. So for the listeners, I would like to tell you, whenever we are interpreting an ROC curve, the more we go nearer to this 0.1, the better is the predictive power, or better is the sensitivity or the predictability of that test to screen that disease. So for the higher the AOC or the higher the area, more is the area, the better is the test. So for uterine artery PI as a standalone marker, the AUC was 0.934. For PAPE, we calculated the AUC as 0.233, and for serum beta HCG it was also very less, 0.416. Now we also took the one good thing about ROC is it also tells about a cutoff value. So an optimal cutoff value we found for uterine artery PI as 2.8, for PAPE as 0.27 or less, and serum HCG 0.5 MOM or less. So when we see the sensitivity of uterine artery PI at this cutoff was 79%. For early onset preeclampsia, which was defined as less than 34 weeks of preeclampsia developing at less than 34 weeks of gestation, the sensitivity was even higher, that is 83.3%, and gestational hypertension, it was poor, 20%. The specificity was overall very good for uterine artery PI. Now coming to PAPE, we can see that the sensitivity was 44.4%, and again early onset preeclampsia it was 50%, while serum beta HCG it was not at all a good predictor for preeclampsia and had a very little sensitivity, like 20% sensitivity only for gestational hypertension. Now when we the previous table we showed standalone markers. Now we tried to combine all these markers. So when we combined uterine artery PI with serum PAPE, the sensitivity for preeclampsia was 44%, and for early onset preeclampsia it was 50%, while the specificity rose to 100% for preeclampsia, and early onset preeclampsia it was 98.9%. On addition of whenever we combined HCG with any either uterine artery PI or serum PAPE, the sensitivity it was not found at all to be sensitive for preeclampsia. However, it had good specificity for preeclampsia and gestational hypertension. So on summarizing the result, uterine artery PI was the most sensitive marker for preeclampsia, and it's 79% specificity. The next most sensitive marker was serum PAPE, and serum HCG had poor sensitivity but high specificity in prediction of preeclampsia. When combining the markers, serum PAPE and uterine artery PI had overall 44% sensitivity and 100% specificity. That is, the sensitivity of the combination was not superior to uterine artery PI alone, but the specificity was raised only marginally as compared to uterine artery PI alone. So same thing, I have put a screenshot. And for combined marker, addition of HCG to either serum PAPE or uterine artery PI was not sensitive for preeclampsia. The specificity of combination was only marginally increased when combined to uterine artery PI alone. So previous studies have also discussed uterine artery PI. It is known that it is a good predictor of preeclampsia. In our study, the cutoff was 2.8, but when we compare it to other study outside India, it was 2.35 to 2.6. This could be secondary to ethnic or regional variations. The sensitivity of the test for predicting preeclampsia was 79%, and gestational hypertension was about 20% only. And we concluded that sensitivity increases with severity of hypertension from preeclampsia to gestational hypertension. Others authors have reported sensitivity values ranging from less than 50% to 100%. So specificity of uterine artery PI in predicting PE was 98.9% in our study, and other authors have reported it in range of 56% to more than 90%. So you can see there is vast differences between the predictive values which are coming from the past researches. This is the table which I took from the article, and you can see that I've again highlighted the 95th percentile, or the cutoff of ours was more, and our sensitivity it was about 78%, while some have given 100% sensitivity, others have even given 23%, others 22%. Specificity was also 98.9% in our study. As a standalone marker, low PAPE has been reported in women who subsequently develop preeclampsia, small for gestational age infants and spontaneous birth. and our cutoff at less than 2.7 MOM was lower than cutoff reported by some of the authors, namely Ozdemir et al., who had given a cutoff value of 0.4. And this could be, we could attribute this to the differences in lab standard for calculation and processing of the samples, and in addition to differences in regional and geography variations. As already said, the sensitivity of serum PAPE as standalone markers were 44.4% and 50% specificity, while other authors have reported a lower sensitivity, less than 20% for preeclampsia. One an author who has worked a lot on this, Poon et al., has reported a sensitivity value of up to 80 to 90% when serum PAPE was combined with maternal characteristic like age or mean arterial pressure. I'm again showing the PAPE values as discussed previously. As a standalone marker, SCG did not perform at all for screening of preeclampsia, but it had very good specificity. And similar to our study, one Ong et al. Has also reported it has a very poor sensitivity in prediction of preeclampsia. So when we combined the test, I've already told you that the sensitivity was 79% for uterine artery PI alone, and when we combined it with serum PAPE, it was 44.4% and specificity was 100%. So Poon et al. Had reported that PAPE does not add to sensitivity of combined screening tests, including maternal age, uterine artery, PI, and MAP for late onset preeclampsia. Some other authors have also reported that combined maternal factor, uterine artery PI, placental growth factor can predict 75% of preterm or less than 37 weeks preeclampsia with less than 37 weeks onset, and 47% for term preeclampsia. Some other authors have also reported a specificity, very high specificity value of 94.4% for combined uterine artery and serum PAPE. Similar to our study, the combination of serum HCG with either PAPE or PI has also been reported to have a very low sensitivity for prediction of preeclampsia, but an acceptable specificity. So the limitation of our study was the study sample size was small, and external validity is questionable. For this, large scale randomized trials are needed. And one of the positive things about the study was that was the first study that came from India. All these studies had been done from outside India. So in conclusion, our hypothesis that addition of serum PAPE and HCG adding to predictive value of uterine artery PI for preeclampsia was proven wrong. Moreover, high cost of biomarkers make them unfeasible for low middle income countries like India, and hence we do not recommend their routine addition to uterine artery PI in screening of preeclampsia at 11 to 14 weeks of gestation. It's the bibliography. Thank you. Thank you, ma'am.
Any comments from chairperson?
Congratulations, Dr. Zeba, for that confident presentation that you made. And I have a query. So you said that, adding these biomarkers doesn't really improve the prediction of preeclampsia. But the fact remains that routinely these biomarkers will be advised for aneuploidy screening.
Yeah.
And
Yes,
in
ma'am.
fact, in a lot of government setups, uterine arteries screening is a challenge and is not being routinely done. So can it still be used for some kind of prediction or estimation of the risk of preeclampsia in the high-risk population?
Ma'am, most of the studies which have been done, they have done the uterine artery Doppler velocimetry testing at 22 to 24 weeks.
Okay.
But our study, it was like first trimester, and the aim, one of the reasons we tried to combine uterine artery Doppler at this point was because we are advising dual marker at this gestational age. So
Yes,
since
and
there were,
if I'm
yes,
not
ma'am.
mistaken, even the ISO guidelines recommend preeclampsia screening by means of uterine artery Doppler at this
Yes, ma'am.
gestation
They,
itself.
ma'am, at that time of undergoing the study, it was well known that uterine artery Doppler is having a overall okay sensitivity. Like I've already told you, like 56 to 70% sensitivity was there already reported. So our purpose was that do we, if we add these placental biomarkers, so will it help or will it not help in these
Yes.
women?
And I think this is another important point which your paper is conveying, that we may not always have a positive outcome or agreement with our hypothesis that we
Yes,
started on.
yes, ma'am.
Some of our outcomes may be in disagreement, and it should always be adequately accepted and documented so that we can in future improve the research design or the methodology.
Yes, ma'am.
And the hypothesis. Yes.
Yes,
And so,
ma'am.
if at all you have to do this study again or in a different way to give better outcomes, what would you like to do?
Ma'am, this study, ma'am, I would like to change some of the biomarkers. Ma'am, you were saying that taking the same biomarkers, ma'am, because there are a lot of biomarkers that are coming up, ma'am, like
Yes.
endogene and everything. So, like SFLT and PLGF ratios, which is routinely being advised, and many labs are doing all these ratios. So, in our hospital, also, we are doing SFLT and PLGF ratios, but not, ma'am, for screening purposes. We are looking at it to see within 7 days how the patient is a patient of preeclampsia, how if the values are above the cutoff range, then the risk of severe changes or adverse outcome increases. So we are using SFLT PLGF ratio for that purpose. In patient who have already developed preeclampsia, not for the screening purposes.
Okay. And is there a pre-existing preset algorithm or calculator wherein we can enter these uterine artery and biomarker values and get a risk prediction? Or did you have to do them individually and combine?
Ma'am, at that point of nowadays, the FMF is providing a criteria tool which you can find it on FMF website. But at that point of time, when I was a postgraduate resident, there was nothing like that. So I had to take the lab reference value, and then I had to make the MOM myself and everything. So it was a tedious task for me, but still I did that, ma'am.
Okay. Ma'am, if anyone else in the
Yeah, Dr. Ashwini,
group
Dr.
has any comments or queries.
Dr. Jaideep has logged in. She said in the beginning that it is her topic of to the very close to the heart. So if
Yes,
Dr.
ma'am, it's
Jaideep can
actually
hear us,
because
she can
we are
share her
still,
experience.
yes, ma'am, and we are all still struggling with hypertensive disorders and their complications. I can see Jaideep madam is still online, but
Yeah. Dr. Ashwini and Dr. Ramni Devi, any question? And Sunil wants to ask something.
No, I just want to congratulate Dr. Zeba. Your real hard work has culminated into a good Indian study. That too, you being postgraduate student that time, and importantly, statistics part. Because we really do not have studies who ultimately gives us sensitivity and specificity with such detailed work and ARC and all. So very
absolutely.
good study, madam.
Thank you,
Yes,
sir.
I
And
just
as
wanted to ask.
critical appraisal, Dr. Dipti asked you to, ask you a few questions regarding how it can be improved even more, or how it can be extended further, giving to other postgraduate students now.
Yes,
So that
yes,
is part of critical appraisal.
yes. Thank
Ashwini,
you.
madam, you want to ask
I
something?
wanted to ask that what about the finances? Because to do all these markers and all,
Ma'am,
did you have some research grant, or the patients only had paid for
no,
the?
no, ma'am. Patient did not pay. The hospital had paid, and because it is a central government hospital, so we have to write a letter, and then it comes. the material come in the biochemistry ward only.
So
So
that
I
is
didn't
good
have
that the
to.
patients didn't have to spend extra.
No, ma'am. Not even a penny. And scans I used to do myself. I first got trained from a radiology professor, and then I started doing the scans myself. So it was all.
Clearly, you have put in a lot of effort in your genuinely done very elaborate study.
Yes, ma'am.
And Ashwini madam, see the knack what she has, been utilizing here is she had taken NT scan, which comes with a Doppler, and she has taken markers from the dual marker. So this is a knack. This is a message to all the delegates. We can do our research studies, having our parallel clinical course continuing.
Yes, sir.
So
At
no
the time
need
of
to spend
NTM, we
also
scan
extra.
only at the same time uterine artery Doppler can be done, and it is known that it has good predictive value for preeclampsia.
So when you came to know that whatever with the uterine artery values or even PAPA values, etc., that there is a risk for PIH, then how you will take care of the patient? How you will use that data for improvement of the maternal this mortality morbidity to reduce that?
Ma'am, first of all, there are, like in our routine settings also, we are following if a patient is having that much less cutoff value, 1.15 that I had got. If the PI value at that point of time is higher than that, then I would just prescribe them, even a primary gravida who has come to me, I would prescribe them ecosprin at that time, which has been endorsed by most of the international bodies that it is preventive for preeclampsia.
And were the results told to the patients? Because see, not every patient will, they will understand that what you are doing, why you are doing. So did they ask you that you are doing this extra test? So why you are doing? What
No, ma'am.
advantage I will get?
Part of the consent, we always tell them before that this is a part of project, and if you are willing, then only we'll take it, and we'll take some samples from you and all those things, and we'll do a scans, ma'am. It was done. Informed consent was taken even prior to enrollment into the study only, ma'am. So the
Did they
patient.
ask you that what is my result? What is the outcome of all the tests in that particular patient?
Ma'am, in that particular patient, yes, we would tell them, ma'am, ki, ma'am, as a analysis, so it was बाद में we analyzed after the delivery. Now we followed it up till delivery.
So they were not told anything during the pregnancy that what is the outcome of your test which you had taken.
Ma'am, we could just give them values because MOM values I had to calculate it by myself. So the values which came in international units, I just gave it to them, and those values they already, ma'am, they had no. I mean, ma'am, we could not tell them that it is high or less because we had to follow them till delivery. And after they delivered, and after my study was completed, then we took out this result. So it was for the betterment of other patient, for the other lot of patient, not for this particular group of patient.
So that also was told to them that the results will be for a research and it is not for her own
Yes, ma'am.
benefit.
It was it was a very
So we have to
detailed.
be very careful about when you are doing any research.
Yeah, because
Yes, ma'am.
what if a patient has an abnormal double marker for aneuploidy screening? Then what was your protocol? Would
Ma'am,
you
at that
disclose or
Ma'am, at
exclude her
that
from?
point of time, we have a dedicated fetal medicine clinic at our center at a hospital. So I would refer them to the specific doctor or the person or the specialist who is looking after these patients, ma'am.
So
And
this
they would get
100 was
counseling there.
this 100 was the final sample
Yes,
size
ma'am.
after all
Final
this
sample
sampling.
size. Yes, ma'am.
It was a very good presentation, Ziba, and we also take our authors to present from the junior category, so they are encouraged, and other juniors are also encouraged. And Dr. Ashwini asked you that when the UF value is high, then do you treat? So you said yes, we do treat the patient with the ecosprin. So is it the reason why your analysis showed less number of PIH patient, preeclampsia patient, because you treated them, Or in one group you did not treat them, what happened, and the other group you...
Ma'am, this was an absolutely observational study. It was not an interventional study. So,
Because you said prospective study, no? That's why I was...
prospective observational, ma'am. We just observe.
Observational.
It was not a trial or a interventional study. It
So
was
you
not.
did not give them anything, right?
No, at that point of time, we didn't give them anything, ma'am. It
No.
will be if I that ma'am asked ki what all can you do. So the next thing that we can plan is that we can give ecosprin. We can conduct an RCT on this topic and we can.
Yeah, I totally agree. So it was an prospective observation study. Still, you wanted to take out analyze. So that's why you
Yes,
did not give anything to this patient in spite of knowing that she may develop, preeclampsia, right?
Yes,
So,
ma'am.
okay, fine. That should be okay, and then they've come out with a good study. And I wanted to know the people. This was observation study, and the mothers, we did not give any medication as a preventive aspect. What was the outcome? Did they go into eclampsia, or only they had a PIH, mild to...
Ma'am, we didn't report any case of eclampsia in our case, but there were 9 patients who developed preeclampsia and 5 developed gestational hypertension.
But a severe or mild one, anything, any idea?
Ma'am, like we didn't actually categorize. The objective was not to categorize them into severe or non-severe, because at that point of time, ma'am, the concept of mild preeclampsia and preeclampsia was there when we conducted and the protocol was submitted at that point of time. So it was only preeclampsia or gestational hypertension. Severe or non-severe was not in the primary
Yeah, that
outcome.
is okay. That you did not analyze. But you
Yes,
analyze that so many people develop preeclampsia or
yes,
gestational
yes, ma'am.
hypertension.
Yes, ma'am.
Okay. So you did not analyze who developed severe and who developed mild one.
Yes, ma'am.
Right? And nobody went into eclampsia.
Nobody had eclampsia.
Okay, fine. Okay. It was a good study.
Thank you, ma'am.
Yeah. I thank all of you, especially Dr. Putambekar, Dr. Madhvi, Dr. Ashwini, Dr. Jaideep Malhotra, Dr. Ramni Devi, and Dr. Our third Dipti as a chairperson, and my team Pragna, Sunil, and both the Pragna Supe. They've done excellent work, and we have been working for this yogi since days together before the day comes, and we are doing, we all are working together, and I have got very good inputs from many delegates, and we'll continue to do work. So we get more and more articles from our members, our juniors especially, who are encouraged to do this research work. And with this, I hand over to all of you, Pragna, Sunil, and both the Pragnas, to say vote of thanks.
Yeah. So thank you so much, Dr. Madhuri Patel, madam. I think the authors are really excited for the next episode that which paper will be selected. I think this is a good, healthy competition. This is going to better our papers, and we have had 6 successful episodes, and we are looking forward to the 7th episode. I would like to thank our chief guest, Dr. Jaideep Tan sir, our guest of honor, Dr. Prakash Trivedi sir, Dr. Jaideep Malhotra, our 3 chairpersons, Dr. Ashwini madam, Dr. Ramni Devi, Dr. Dipti Gupta, and both the speakers, Dr. Shailesh Puntambekar, Dr. Madhvi Patil, and Dr. Zeba Khanam, for excellent presentations, and of course our Master of Ceremonies, Dr. Sunil, Dr. Pragnya, and Maria, our office staff, who has been, really instrumental in making, this program a big success. And I thank all the viewers for their patient listening. So thank you all. And please log in for the next program, which will be on the 3rd Wednesday of September. So looking forward to the next program. Thank you so much, ma'am.
Pragna, and I would like to add that Maria is doing excellent work. She is a big asset to us, and she is after us. So we can do this program, in time and everything in time. So Maria, thank you once again from behalf
Thank you
of
so
me
much.
as well as the whole JOGI team. And I really thank delegates who have logged in. Dipti, thank you.
Thank you so much, madam. Thank you.
Thank you, everyone.
Thank you all.
Thank you.
Ending this meeting for all. Thanks, everyone.
Yes.
Thank you. Thank you.